Today, I want to talk about what the Affordable Care Act, ACA, has meant in practice. First, the big picture. Recent studies consistently show that the ACA's coverage pathways, particularly Medicaid expansion and the individual marketplaces, have driven sustained gains in insurance coverage. But the more important finding is what coverage did. Research since 2020 links expansion to more primary care visits, greater use of preventive services like cancer screening and diabetes management, and earlier treatment for chronic conditions. When people get insured, they use care sooner and more appropriately, and the health system functions more like a system and less like a safety net of last resort. Second, health outcomes. Several contemporary analyses associate Medicaid expansion with measurable improvements in population health. Lower mortality for some conditions amenable to treatment, better postpartum care, and more stable mental health and substance use treatment access. The pattern is not uniform across every measure and every state, but the direction is clear. Coverage expansion correlates with healthier outcomes over time, especially for groups that were historically uninsured. Third, financial security. A wave of studies since 2020 tracks what happens to household finances when medical bills meet thin wallets. The evidence shows declines in medical debt, fewer collections, and fewer evictions in places that expanded Medicaid. Families are less likely to postpone needed care because of cost, and they face fewer catastrophic bills. In short, insurance functions as insurance. Fourth, equity. Recent scholarship finds that the ACA narrowed racial and ethnic gaps in coverage and access, particularly for Black and Hispanic adults, though it did not erase them. Where states expanded Medicaid, disparities in having a usual source of care and in foregoing care due to cost narrowed more. Where expansion did not occur, gaps persisted. Policy choices mattered, and they mattered unequally. Fifth, hospitals and local economies. Studies over the past few years document reduced uncompensated care and improved operating margins for hospitals, effects that are especially salient for rural facilities. That financial stabilization supports service lines like obstetrics and behavioral health that are often first on the chopping block when money is tight. Researchers also note spillovers. When hospitals face less bad debt, communities face fewer closures and better access. Sixth, the marketplaces. Peer-reviewed work examining recent subsidy enhancements suggests that lowering premiums at the point of purchase increases enrollment and improves risk pools without the feared spikes in net spending per enrollee. Consumers respond to affordability and clarity, and when plans are affordable, take-up rises. Finally, the caveats. The ACA remains a floor, not a ceiling. Coverage gaps persist in non-expansion states. Network breadth and out-of-pocket costs still deter some people from seeking care. Administrative complexity can slow enrollment and re-enrollment, issues underscored by the recent unwinding of continuous coverage in Medicaid. And while access has improved, achieving equitable health outcomes requires continued attention to primary care capacity, behavioral health integration, maternal health, and social drivers of health. If we distill the last 5 years of research into one sentence, it is this: when coverage expands and remains affordable, people get care earlier, financial strain eases, hospitals stabilize, and health inequities narrow. The ACA did not solve every problem, but the evidence shows it moved America's health system in a healthier, fairer, and more financially